Alice. I work in the admissions and outreach team here at BSMS, and thank you for coming along to our monthly lecture today. So just a little bit of housekeeping before we get started. I'm going to record the session. We record all of the sessions in the monthly lecture series. That's so that they're accessible and get added to a YouTube playlist we have, so anyone can watch them at a later date. So you won't be in the recording yourself because this is a webinar, but if for any reason you're uncomfortable with the session being recorded, we will unfortunately have to ask you to leave. This evening, we'll be using Menti. I will put the code for Menti into the chat when we get started. Menti is essentially an interactive feedback website, so you can kind of respond in real time to some of the questions that we'll have in the talk. So like I said, I'll share the code for that via the chat, and you can log on. It's very straightforward to use if you've not used it before. If you've got any questions throughout the talk, you can put them in the Q&A function at the bottom. Please don't put them in the chat because they will get lost in the ether and they're a lot harder to kind of find again. So if you've got questions, please do put them in the Q&A function, and then we will have a bit of time at the end where we'll be able to respond to questions. If there are questions about kind of admissions or anything related to getting into medical school, myself and my colleague Claire will respond to those as we go. But if they're related to the talk itself, then Dr. Tom Levett will respond to them at the end, depending on how much time we've got. Wonderful. I think that is everything for this housekeeping side of things. So I will introduce our speaker for this evening. So we're joined by Dr. Tom Levett, who is a consultant in elderly medicine and senior lecturer in Medicine and Frailty at Brighton and Sussex Medical School. He completed his PhD here in Brighton on HIV and ageing. He is the head of years 3 and 4 of the undergraduate programme at BSMS. So welcome. Thank you so much, Dr. Tom Levett, for giving up your time tonight. And I will now hand over to you.
Hi, everyone. So I'm Tom. Yes, I'm a consultant geriatrician, so I look after older adults, and I am a researcher and a teacher here at the medical school in Brighton. And I'm really pleased to be talking to you. I can't see any of you. I don't know how many people are here. I hope you can hear me all right. I'm in very unglamorous surroundings. You can see our fridge and selection of teas behind, but we'll do our best in these in this environment. So here's my talk. I hope you can see it. When Grannies Attack, Aging and Health Problems in Later Life, and we'll come back to the attacking grannies later on. I'm a geriatrician, so that means I advocate for and look after older adults. So this will be no secret that I'm really promoting the care of older adults during this talk. So I'm going to be switching between the talk and Menti. I've had a bit of a practice, but this is new to me. So this is going to be our first question, where you're from. So I'm going to switch on to Menti just to get a feel for where you're from. And then I'm going to tell you a bit about my journey to where I am now. So if I just pause this one and here. Hopefully you can see. Oh, you're all doing it already. Amazing. Okay, this is working well. A lot of people from London, some people from Brighton. I'm phoning in from Brighton. Got some local people. Portsmouth. Portsmouth features in my past. Leeds, Lancing. Yeah, great. Cardiff. Cardiff also features. Good. Gosh, I've got some local people, which is really good. I'm just watching it, like I'm mesmerized by everything here. Okie doke. All right, good. Any people? Hong Kong, I can see. Poland, Singapore, very nice place. Brussels. Oh, international crowd. Okay, great. And Hove. The all important Hove. Okay, Brill. Okay. People are participating. I can see we're up to 170. Okay, it's kind of paused there. You didn't get to Victoria, we've got Canada. God, this is brilliant. I love this. Okay. Well, thank you, everyone. Italy, I can see. Haywards Heath. Big part of my training, Haywards Heath. Okay, Brill. Okay. So I'm gonna pause it there, and I'm gonna bring you back to the main presentation. can see that you're all contributing. Newport, brilliant. I don't know if that's the Isle of Wight or whether that is Wales. Here we go. So this is about me. So I am from Sussex. Sussex is my home county. I'm from a little place called Ford. I went to a local comprehensive school in West Sussex, which doesn't exist anymore. Westergate Community College, that's gone. So it didn't have a sixth form. So I went to South Downs College, which is just outside Portsmouth. We had some people from Portsmouth, which is in Waterlooville, and I did my A-levels there. And they were brilliant, and they'd never sent anyone to medical school, and I didn't really know what it meant to go to medical school. So I was very lucky and fortunate to get a place at medical school. This is quite a while ago, 1999. I applied. I didn't really know what was involved. There's a lot more available now for you guys to support you in your journey to become doctors. So I'm really pleased. I'm really happy to be part of your process of getting to medical school. So from college, I travelled to South Wales. I did my medical school degree in Cardiff. So I saw people there that were from Newport, and that may be South Wales. I did my obs and gynae placement in Newport, delivered some babies there, which is exciting. I stayed around, and you may be getting used if you're doing some of the virtual work experience or learning about the system. So once you qualify, you're a foundation doctor for 2 years. It came in the year that I graduated, and I spent my first 2 years working in Cardiff. And then I decided that I wanted to train to be a physician, so a general physician. So from Cardiff, I went back down the M4 to London, and there was quite a few. Most of you are dialing in from London. And in London, I did my what's called core medical training, which is now called internal medicine training. And then once you complete that, you decide on your specialty. Medicine's very broad. And I'd always had a passion for old age medicine since I worked in or was at medical school in Cardiff, and particularly when I was on placement. I don't know, I didn't see if anyone's calling from Llanelli, which is just past Swansea, but there was an excellent geriatrician there called Granville Morris who really inspired me. So I continued and decided to apply for a job in elderly medicine. And I was fortunate enough that they were developing a training program here in Brighton. So I came here. So I did my training here, and then worked in Chichester and Worthing and Haywards Heath, which will mean something to the local people, but perhaps not those of you that are further afield. My first job was in Chichester, which is the hospital that I was born in, and also the hospital that I did my volunteering in. So when I was thinking about applying to medical school, I did some volunteering in my local hospital. And weirdly, when I graduated and I applied to be a geriatrics registrar, my first ever registrar post was on the ward I was a volunteer on, and both the ward sister and the ward clerk were still the same person. So they were really inspired by the fact that actually it does work, and people do come back as doctors, and you do go off and train. So as Alice said, I did my PhD here, and my research interest is in HIV and aging. I'm not really going to talk about that today, but that's a growing area, is looking at aging within groups where perhaps aging has been neglected or not needed. People are surviving much longer now with HIV. So that's a really inspirational tale in itself, that the success of antiretroviral therapy for people living with HIV means that they're surviving to normal life expectancies, which wasn't expected at all when the HIV epidemic started in the early 1980s. What I'm calling my proper job is when I finished my training and I became a consultant, and I look after older adults here in Brighton, and I work at the medical school. So half my time is spent at the medical school, and I'm responsible for years 3 and 4 of the undergraduate curriculum. So if you do come here, I will get to meet you. Okay, so this is me, post-COVID, pre-COVID. The beard had to go during COVID, but it's back again now. So what I do is I do acute geriatric medicine, which means I look after people in the emergency department who are older. We actually decide who we see based on frailty. So I'm going to talk a bit about that later on in the talk, but that's a state whereby people are vulnerable to various changes in their functional status because of ill health. So we don't necessarily always look after very old individuals. We sometimes look after younger individuals who have got needs that are best met by an elderly medicine physician. I also do rehabilitation medicine, so people that have been in hospital for a number of things, like they've had an operation, or they have been in intensive care, or more recently they've had COVID and they're coming to us to rehab to get back to their normal level of function before they can go home. Or if that functional status has changed and they perhaps can't do the things that they used to do before, we're helping them to adapt to that and put in care and resources to help them be at home with their new sort of set point, really. I'm a teacher. I teach elderly medicine. I teach general medicine. I teach topics related to frailty and HIV. I do course coordination. So as I said, I'm head of years 3 and 4. And I research HIV and aging. And I also research medical education and how we teach people about elderly medicine and frailty in particular. So that's me. And this is elderly medicine. So medicine is changing a lot, and I think it's brilliant. And there are a lot of inspirational people in medicine. And for all geriatricians, this woman is very inspirational. And it's, I think, even better that we have a mother of geriatric medicine, rather than people talk about lots of medical figures and they're the father of, because there's a lot of men that dominate medicine in the history. But from geriatric medicine point of view, very proud that the founder is Marjorie Warren. She qualified in 1923, which was a feat. She qualified as a surgeon rather than a physician, and was given an old-fashioned workhouse to look after, where there are a lot of older adults that had been left there and institutionalized with no one to look after them. And she very quickly went in and tried to look at the problems that people had, to work out whether there were people that she could treat, there are people that she could offer rehabilitation to, like I do, or there were people that needed full-time 24-hour care. And that started various movements. So it started it was the end of workhouses. It was the start of residential care in the form of nursing homes. And it was the start of elderly medicine. And she published on her approach, which was multidisciplinary, using not only medicine but specialist nurses, starting to get allied healthcare professionals to give these patients a lease of life, really. She published on the subject, and she worked hard with the Ministry of Health to recognise geriatric medicine, which was accepted in the 1950s. So it's one of the younger medical specialties, although we represent the largest group of physicians in the UK now. And these are the foundation principles of geriatric medicine, which was about disease prevention, reducing disability and getting people as functional as possible, promoting independence, and again, to adapt to any disability that's left. And a lot of these are really founding principles in terms of how to age successfully. She sadly died in a car accident before her time, age 63, on the way to a medical conference. So that's a bit about Marjorie Warren, and she went on to form the British Geriatric Society, which still exists and that I'm a member of today. So we're going to start by talking about age. So we're going to move to Menti, and I've got some pictures there, and I want you to think about which of these animals has the longest life. We'll switch to Menti, and then I have I've reproduced them there. Bear with me. How do I move to the next? So which of these animals has the longest life? We've got the bowhead whale, the Galapagos tortoise. Oh, look, everyone's voting. The Greenland shark, humans, the ocean quahoog. Okay, I'll give you a bit of time. The tortoise is popular. There are a number of Galapagos tortoises. There are some famous ones as well. Lonesome George was the famous one, who died, sadly, recently. Okay, it's petering out. Okay, so you've all gone for the Galapagos tortoise. In second place is the ocean quahoog, Greenland shark, and the human and the bowhead whale have the same. Okay, great. So I'm going to bring us back to the presentation. Put you out of your misery. So it's actually the ocean quail, which the longest lived of its species is 517 years old, based on the techniques they have to age them. Then we have the Greenland shark. It lives in very cold water, so it's very slowly growing. It doesn't mature until around 100 years. The bowhead whale is 211 years, and the oldest example they know of, they've put at 211 years because they found a harpoon in it, which they could date the harpoon. The Galapagos tortoise, the oldest reported, is around 177, and the oldest recorded human is here. She's called Jeanne Calment. She's French. We're going to go back to Menti because I want to ask you how old the oldest human is. There's a lot of moving around. Sorry. Okay, so let's move on. Okay, how old is the longest, or was the longest lived human? She's sadly not alive now. I've got two screens. That's why I'm like looking between. Okay, so I know sort of how many people are voting now, so we're sort of getting there. Okay, so we've gone for 122 years. Okie doke. Okay, so that's the right answer. She lived to be 122 and 164 days old. It's quite an interesting story. She took up fencing in her 90s. She rode her bike until over 100 years old. She did a deal with a French lawyer to sell her house. And he sort of paid for her, but she ended up outliving him. So it ended up costing his estate money to keep her, although he was doing it as a kind of way to create money for himself. In terms of the figures that I gave you, the maximum anticipated lifespan for a human is 129 years, but no one has achieved that yet. There are people that claim to be older, but Jean-Louise Calment is the person that could prove their age. So this is obviously just to get us going. So I'm back to Menti, and we're going to have a think about at what age do you stop being young and at what age do you start being old, because what the definition of old is fairly problematic, as you can imagine. Okay. Then we're going to have a bit, there won't be some Menti for a while. I'm going to talk to you. So what is young and what is old? So at what age do you stop being young and at what age do you start being old? So if you could vote. Okay. I wasn't sure how the slider would work, so I'm interested to see how this will happen. I obviously don't know your ages either as an audience, but I'm presuming that you're all younger than me. Well, not all, most of you. I'm going to show you some data from the Office of National Statistics when they did this study. I'm sure they could benefit from this kind of mechanism. Okay, so there we go. We've chosen 35 is the average that you've stated. Obviously, there is a big range that you can see, and 58 when you start being old. Okay, let's pause that. So 35 and 58. So this is data from a big study, YouGov study, where they asked these people exactly the same questions. This is asking British people what they think. And you can see as you look around the general population here, I don't know if you can see my pointer, the general population are here, and then you've got the different age groups that have reported here. And the darker the color is where people put it, essentially, where the majority put the age. But on average, so you're quite close to what people thought here, is that most people thought that you stop being young around 30. So I've passed that point now, so I'm no longer young. And you start being old on average, where we get to the 70s here, So on average, you start being old at 70. So you guys have put you start being old much younger. So that makes me think, I'm hoping that we're talking to a younger audience here, because actually, if you look at sort of the 18 to 24s and the 25 to 29s, they did set this earlier. So they put it at around 65. And what you can see is, if you look at the figures here, that as you get older, your perceptions change and you move where you feel further away from where you are. So then there's this middle ground between about 30 and 50 where you're sort of nothing, and then from 50 you start being middle-aged, and from 70 you start being older. So thankfully I'm not middle-aged yet, but I'm in this sort of no man's land. It's difficult. There isn't a set definition of old, and choosing a cutoff in terms of an age is a little bit problematic, because it's never going to suit all people, and it's always going to be you don't want to fall into the category. And like I say, as you get older, you push it further away from where you are, because your perceptions of how you are and comparison to your peers are very different, and we'll talk a bit more about that. So back to Menti, I'm just interested to think about, what does old age make you think of? So this is going to ask you to give us a word that you associate with older age. So what's the first word that comes into your mind when you think of an old person? And I've deliberately used the word old person. Okay. Oh, I'm really looking forward to this. Okay, so we've got frail, wrinkles, wise, wisdom comes out, experience, retirement, mean. Okay. I think there was cabbage there somewhere. Is that right? Tea, yeah. I'm definitely in that cat. I'm old if we're rating it on tea. Infirm, health, sad, fragile, grandparents, yeah. Retirement, not independent, incontinence comes up, funeral, smelly, injured easily, deteriorating, Botox, adventure, chess, loss, death. So the biggest one is frail. I guess that's very topical now, and I'm senior lecturer in frailty, so I have an interest in that. Wrinkles, grandparents, wisdom, wise, death, weak, and experience. Okay, brill. Okay, I'm going to pause that, come back. So, So aging is often seen as a time of loss, actually, and there's a lot of negative language around aging. And I deliberately use the word old person, whereas now we probably prefer older adult, and referring to it as sort of using an adjective rather than a sort of a title of old person. That's what you are. There are a lot of losses, and you kind of alluded to these in your comments there. There are societal roles that you lose, particularly with retirement, and retirement age is changing. We're all going to be working longer. I don't know what age you'll be all working until. I'm expecting to work until my late 60s, and by the time I get there, who knows what the retirement age will be. There's other losses. So societal networks, you lose networks through bereavement, loss of partners, loss of friends, and there's potential financial disadvantage. There's a lot of pensioner poverty in the UK. There are losses around physical health or sensory losses, and some of those are age related and expected. Our vision will reduce as we get older, our hearing will reduce as we get older. Some people may experience functional decline and disability. Some people may experience loss of memory. There's this idea of life space, which is how much space in the world is available to you. And that tends to shrink as you get older. So you sat at home, actually, your life space is currently limited depending on where you are in the world. And that's because of the global pandemic. So you are limited because of what's happening in the world. If you wanted to get on a plane and go somewhere, you can't, because there are restrictions. But if they weren't there, your life space would be unlimited. But as you get older and your functional capacity, your ability to do things for yourself changes, your life space tends to shrink. And you might get to the point where you are living in what might be what we call a micro environment. So one room living, where your life space is confined to that. And it may shrink even further right at the end of your life, for your life space to just be your bed. And you can't get without outside of the confines of the bed independently based on your functional status. Your independence may be lost alongside, and autonomy, which is your ability, it's one of the pillars of ethics, your ability to decide for yourself. And that may be because you can't communicate, or because you have memory impairment, or your voice just isn't being heard. And I really see it as part of my role as a geriatrician to be an advocate for older adults, to make sure that we don't promote ageism within university settings and with healthcare settings. But, you know, on the flip side, it was really nice to see some positive responses there, that aging is a time of gain as well. And I've got wisdom as the top of my list, and I'm really pleased that that was one of the prominent words that was there, was wisdom. Also, there's a lot of evidence that older adults are happy, and they're happier particularly than people in middle age, and they may be happier than people in younger age. You may form closer emotional connections if you've been with someone for a long time, as your family grows and you get generations of family. You may also, though there's pension or poverty, there may be financial security at the time of retirement. You may own your own home, and you may not have to worry about things like bills and mortgage payments, for example. And then there's freedom if you're not tied to a job or a place, and if you have got the ability to move, to do whatever you like. A lot of people find that they have freedom, particularly freedom of speech, and they feel that they can find their voice in older age and say what they like. Whether well-being is enhanced in older age depends on how well you're aging, and we all age differently. So aging. The UK has an ageing population. In fact, the world has an ageing population, but the UK in particular. So these are data from Age UK from last year, 2 years ago now, 2019. So there are around 12 million people in the UK that are over the age of 65. And from a statistical standpoint and how we record things, 65 is still taken as the point at which we consider someone to be an older adult, and we might consider, from a sort of statistical or collecting data terms, people over the age of 80 to be the oldest old, though those will inevitably change. You know, a 65-year-old today is not the same as a 65-year-old 20 years ago, and it will not be the same as a 65-year-old in 20 years' time. And we hope that if we carry on the trajectories that we're on, that the 65-year-old in 20 years' time will be very fit, and we might all be living to greater ages. And we're going to talk a little bit about life expectancy. So you can see that we've got 1.6 million people over the age of 85, and about 15,000 people that reached their 100th birthday. But this is going to increase, and the biggest group that are going to change are going to be those people over the age of 85, and particularly those people that are reaching 100. So our population is getting older, and this is happening all around the world. So it's nice what you're all coming from different regions. So the globe is aging generally, and some of us our curves have been higher. And you can look at this graph here, and it shows you the different world areas about how things are increasing. And actually, Latin America and the Caribbean and Africa are the largest growing cohorts, where they're getting, over the next projected 30 years to 2050, they're going to have the biggest percentage change in older adults as their life expectancy increases. But anywhere in the world, older adult groups are increasing, which may be seen as a plus. There are some difficulties around that, particularly in terms of needing healthcare and social care, but it's our role to adapt to our changing population. So what are the drivers? So why is the world getting older? Well, because of innovation, and because of changes in medicine, and the changes in public health, and the changes in governmental decisions, really, that are promoting public health. So we get a reduction in childhood mortality. So we don't have so many children that are dying in the first 5 years of life, which brings the average age of death up. We've got improvements in sanitation, in nutrition, and generally in public health, so that people aren't dying unnecessarily in particularly childhood and younger years of things like diarrheal illnesses. Advances in medical care mean that people survive with illnesses longer. So if you take cancer, for example, or a diagnosis of any chronic disease, diabetes, the care of that individual is much better. So they are surviving to a longer age with that. If we think of other conditions like cystic fibrosis, which affects predominantly younger people, it's a genetic condition which used to have a life expectancy in the sort of teens and 20s, which is going up to the 30s, 40s and 50s now. So advances in medical care is meaning people live longer with medical problems. There are changes in our lifestyle, which are at varying degrees around the world, how quickly we are catching up with these. But particularly, in Western society, smoking is reducing, alcohol consumption is reducing, but I've put obesity in bold, and that's on the increase. And that might be something that causes us to slide backwards, particularly in terms of life expectancy and health outcomes as we as societies get bigger and larger, and we have to deal with obesity-related illness. There are other factors such as education and improvements in work practice. So improvements in work practice, particularly around health and safety and manual work, has definitely reduced mortality and early life years, particularly for men. And education is absolutely vital in improving individuals' life chances. And that has a real big role in low and middle income countries, particularly in women. And we're seeing a reduction in poverty generally, although there's a lot of talk about poverty, and it takes crises like this to identify where poverty is and to highlight that it's still a problem that we haven't stamped out. Other factors are post-war booms, particularly in the UK and Western Europe following World War II, and a decreased fertility. And decreased fertility comes with changes in society, and particularly around education, as women have access to education, work opportunities, education around contraception and sexual health choices, which means that fertility is going down generally. And of course, if you have less babies being born, your population is naturally older. And that's important because we need a younger population coming through and particularly a working age population to support that older age group, particularly as our ways of looking after people have changed. So whereas some societies are very still much in a cultural sense that it's the responsibility of families to care for their older generations, that's not so prevalent in Europe and North America, and it comes part of this sort of development of health and education, which means that it falls to health and social care organisations to provide a lot of care as people get older. So back to Menti, you'll be mentied out by this. So I'm going to ask you about life expectancy now. So we're going to move forward. I have paused. I'm going to skip this. Well, we can answer this one. So I've deliberately changed this word to, to granny or granddad, and we'll see if it changes how people think. Okay. Yeah, I mean, immediately I can see that when you put a face to it, or you think about someone who's in your life that's older, it changes the words, doesn't it? So it's deliberately, there's a thing around language which affects older adults, and it does have negative connotations, which puts people off the care of older adults, and it perpetuates ageism in society. But when you kind of put a face on it that like your grandparent, then it changes to nicer words. So there we go. So love, kind, caring. I mean, dead's quite high, but that's sort of inevitable. That's part of the circle of life, right? Okay. So what is the average life expectancy in the UK for men and women? This is UK because I'm going to show you UK data. So at what age can you expect to live to if you're a man and a woman? Okay, I'm loving this sliding. I think this is good. I'm going to use this. My students are going to be sick of this. So if you come, like in 3 years' time, I'm going to be a Menti whiz. Okay. Okay, so we've got 77.9 years for a man and 82.4 years for a woman. I'm like super impressed. This is really accurate. Okay, so we're going to go back to where we were. Is this in some curriculum somewhere, or was it in the blurb of the talk? So the life expectancy from birth of a woman is 82.8 years. So you're kind of spot on. And for males, it's 79.1 years. And what happens is once you get to 65, your life expectancy resets because you have a survival advantage. So you've survived all that's come before. So you've survived childhood illness, you've survived accidents, which peak in teens and 20s, you've survived early life cancers, you've survived workplace events. So your life expectancy resets, and you can, for a woman, you gain 21 years, and for a man, 18.5. And you can see there the life expectancy at 65 is almost 86 for a female, 83.5 for a man. And then that resets again at 85. So it keeps going up. The longer you live, the more you're likely to live further. So it gives people hope that if you reach to a time, you are going to live longer than the life expectancy. I'm going to talk a little bit about healthy life expectancy, but you can see that that healthy life expectancy, which is the amount of years that you live in good health, is only 63.6 years. And that's the same for both men and women. This is how life expectancy has changed in the UK since 1841. And you can see that females have always had a higher life expectancy, and there's always been a gap, but that gap is starting to close slightly now. There was a big sharp uprise there, you can see, around the time of the 1930s, 1950s, and we get the onset of the National Health Service in the around that time. Why is there a difference between men and women? Well, a number of factors, really. So some of it is to do with occupational exposures and jobs and increased risk in men. Male mortality is higher at all stages. There was also an excess of behavioural, what you might call lifestyle risk factors in men, particularly drinking and smoking, and women took up those practices after men. So we're seeing a peak of sort of particularly smoking related illnesses in men, and we might see that that starts to catch up in women as well. So we might see those curves coming together. There's a little bit of a slowing off, which people have attributed to things like obesity, and COVID is going to have an effect on life expectancy as well, and it may end up dropping life expectancy temporarily. But are people really well in their old age? And this is the idea of good health or healthy life expectancy. So I told you for men, it's around 79.5 years, but the number of years in good health is 63.3, and for female, 63.9. So you're living, the end of your life is not necessarily in good health. Now, that doesn't mean that you have disability, and you can have, there are figures here that look at disability free life expectancy. What this means is that you've acquired medical diagnosis, and as you get older, that's quite natural with age, that you acquire age-related problems. And it's our job as a society, and my job as someone who looks after older adults, is to do what we call compression of morbidity, which is to try and move the number of years, the healthy life expectancy, as close to life expectancy as possible. So we compress or squeeze ill health until right at the end of life, so that people are living as well as possible for as long as possible. And then we look after them for their medical problems right at the end of their life. There's a lot of health inequality, and I think COVID has really uncovered health inequality across the country, and you can see that in healthy life expectancy. And these are data from the Health Foundation, which is a think tank which looks after health and advises government on policy. And the lowest healthy life expectancy is in Blackpool, which is 53.3 years, and the highest is Richmond upon Thames, just outside of London, at 71.9 years. There's an 18.6-year gap between the highest and lowest healthy life expectancy. So even across the UK, there is big changes. So we need to think about this on a countrywide and a global way of thinking to try and push everyone to have as healthy lives as possible. Some of that will be to do with education, excess lifestyle risk factors, jobs that people are doing, sedentary lifestyles and lack of physical activity. So there's lots of things that we can do, and we should be moving towards promoting healthy aging. So the Office of National Statistics has this life expectancy calculator, which is quite crude, really, because it looks at your current age and your gender to calculate your life expectancy and where you can expect to survive to. So this is me on this side. So my average life expectancy is 85 years, but I'm pleased that there's a 1 in 10 chance that I might hit 98. And there's a sort of 6% chance that I might hit 100. And then on this right side is, I was just thinking about who might be attending this. And this is for someone who's age 16, who's female. The life expectancy is 89, and you have a 1 in 10 chance of hitting 101, and a 14% chance of living even longer than, a 14% chance of getting to 100. So sort of 15% of people will get to 100, and even more 101. So we can expect your generation to be being centenarians. So you're going to expect, if you think that you're going to retire in your 60s, there's lots of years to live where you've got to stay well as possible. So aging is the progressive loss of function accompanied by decreasing fertility and increasing mortality that occurs with advancing age. That's a global definition that could be applied. And then a more specific definition at a person level is the deterioration and decline in functional properties at a cellular level, tissue level, organ level, and then homeostasis is what controls body function, so keeping you all at a steady state. And a decreased adaptability, so you can't respond well to stressors that the world throws at you, ill health, drugs, medicines, alcohol, air pollution, whatever that might be. So you're in increased vulnerability to disease and unfortunately death. But it's not standard. We all age at different rates and at different times. So there's this idea of biological aging and chronological aging. And if we go from that definition of the progressive loss of function from decreasing fertility and increasing mortality, chronological aging is how long you've lived for. So that's just the number of birthdays you've had. So that's how much time you've physically spent on Earth. And it's a measure of age in years. And it's a constant rate because a year is 365.25 or years, days, or whatever it is. So you're all advancing at the same rate, but the biological aspect, so your internal aging, so how quickly your cells, tissues, organs are aging varies, and that's your biological age. So there's no standard marker of that. So these may happen in time, and in time we might start to measure people's biological age because it might help us in terms of promoting health behaviors, or there might be treatments, and who knows, in time there may be treatments that halt or stop or try and slow down the aging process. So it would be important to know what your biological age is to try and perhaps put those in place sooner in some people. And things like this are starting to appear. So this is how healthy is your heart, and this is on the NHS website, and you can do this and it will tell you, they know how many years old you are. So, I'm a 39-year-old, but it might tell me based on my risk factors or how much exercise I do or how much I weigh, how biologically old they think my heart is. And if there is a gap between those, particularly if your chronological age, the number of years you've been alive, is less than your biological age, then you're perhaps aging more negatively than other people of your age group. And that might be something that triggers you to think about your own health and your own behaviors to try and move you back towards where your heart age should be. And there's lots of examples now, and I think it's really great that we're starting to see real prominence of older adults that are independent, active, living the lives they want to live. Queen Elizabeth II is 94. She's Britain's longest reigning monarch. She's not the world's reigning monarch yet. She's got a bit of a way to go to beat one of the French kings. Then you've got Mindy Hornick, who's an Auschwitz survivor and educator around Holocaust. And I included her because obviously she's inspirational, but this is a bit about what happens when you do elderly medicine, is that you get to meet inspirational people who have lived a full life and have lots of stories to tell you. And I was very fortunate when I worked in Chichester and I was doing a clinic in Bognor Regis. I don't know if anyone's local to Bognor Regis. And I met a lady who also survived Auschwitz. And, it's very difficult not to spend the time to hear their story, because when else would you get the opportunity to speak to someone who's had those experiences and had that lived experience that they want to share with you? So you will meet some remarkable people if you go into medicine who are willing to share their stories with you. And I think some, older adults have got the most life experience to share with you. Angela Lansbury's a personal favourite of mine, who is still going and acting, age 95. And Iris Apfel, I don't know if anyone knows who Iris Apfel is 99, and she should be an inspiration to everyone. She signed her modelling contract, age 97, and just above here is her Barbie doll. And Mattel Company, which is a toy company, made a Barbie in the likeness of Iris Apfel when Iris was 96 years old. And that's the oldest inspiration for a Barbie ever. And having a Barbie made of you is the biggest accolade that the Mattel toy company can bestow upon someone. And they did it for Iris Apfel. Not leaving out granddads. So we've got some other inspirational people here. Fauja Singh is now 109 years old. He was a marathon runner and holds lots of records for marathon running. He's now retired from that, but he was a founding member of Sikhs in the City, which is a running club in the West Midlands. James L. Jones is in his 90s. He's the original voice of, depending on which generation you are or what you're into, both Darth Vader and Mufasa from The Lion King. And of course, everyone knows David Attenborough. And we talked about life space, and David Attenborough at 94's life space is unlimited. He can pop up in the Antarctic doing a piece to camera, maybe green screen, I don't know, but I'm assuming, and I want to think, that he's got this great life that he can do. He's embracing new technologies. He's still doing what he wants to do. He's still a naturalist. He is taking to Instagram and embracing ways that he can continue in his older age to do all the things he wanted to do before. So these are unlimited individuals. When we think of older age and we think of an old person, we've got very negative language, but you've got a whole gambit of people that are being really showcased as older adults that are living inspirational lives. But there is a flip side. So not everyone is at this end of the spectrum, which is perhaps this, what we might consider to be successful aging, which has its own definition in its right. And then at the other end, we've got perhaps negative aging, which is seen as frailty. And I've just chosen this picture from the internet. And you can see she's a rather thin lady who is in an armchair. It looks like a very stereotypical sort of old person setting, could be a care home, who knows. And in the middle, I've got this kind of idea about these curves that these two individuals may be on. And if you think of the green as being the time where you're functional and can do everything you like, and then the yellow where you're finding it a little bit more difficult and you're at risk of coming into hospital or having medical problems. And then once you get into the red, you've got some form of disability or loss of independence, which may mean that you're reliant on care, or you need a walking aid, or you're in a care home. And we will all get there at different rates. Obviously, we want to be in the successful aging category, but we need a change in the way we think about aging to allow that to happen. So we need to be much more proactive about how we age, how we look at our older adults that are in our life. If we look at our parents and our grandparents and our great-grandparents, if you have them, and what are they doing to help them get into older age as fit as possible? And this is from the WHO, which is really stressing that, really, about that everyone is different, and the influences that come on our older age are based on our medical problems, they're based on our genetics, they're based on our physiology, they're based on the behaviours that we take, both negative and positive. So negative might be around smoking, drinking, carrying too much weight, and then the behaviours that are positive might be around volunteering, keeping active, taking up marathon running or fencing in your 90s. Not that everyone should just start doing that. That won't work for everyone, but for some people it will work. But it's about trying to shift our conversation forward in our lifespan so that we start to think about how we're going to age when we're in our 50s and our 60s, so that when we enter our 70s, 80s, 90s, we're as fit as possible so we can live our lives as actively as possible for as long as possible. And it's about, that's a societal change, and this is what this is saying, really. It's about changing the way we perceive older people and how we perceive ourselves to be aging, and how we're going to get there, and how we're going to make the most of it, and how we're going to get ourselves in the best position. Creation of age-friendly environments, and that's perhaps moving away from care home environments or care to be more supported living generally. And we all as a society look after older adults, and we make it accessible so that people can use public transport, they can access facilities that they need. Certainly other things that are springing up are things like dementia villages rather than care homes, so that people can live within environments, which means that they can continue their lives in a sort of observed environment but doesn't restrict them. Alignment of health systems to meet the need of older people, and the development of systems of long-term care, which are difficult because they're expensive and they rely on a younger cohort to look after an older cohort. So essentially the way we age needs to shift. There needs to be big shifts in low and middle income countries which are not set up to deal with an aging population. So they're going to have to get there quite quickly. So if you do decide to come to Brighton and Sussex Medical School, if that's your hope, we hope to have a new hospital which you'll be able to train in, which will be really nice. So thinking about why older adults come to hospital, and this is the age-related problems section of the talk. So we're going to go back to Menti. Okay. So why do older adults come to hospital? Why might people need to come in? What are the problems that you think I deal with? I love that falls is huge. Yes. Cancer, hip, chronic diseases, checkups, Alzheimer's, mental health. Yeah, I see a lot of mental health problems, stroke. Yeah, loneliness is there, and actually you'd think that wouldn't be a reason why people come to hospital, but it may be the reason that people come, or it may be the reason that people don't navigate health quite well. Those people that are really high users of health, then you may need to step back and say, well, your medical problems are all quite well controlled, so what's actually going on here? And that's, the sort of work that we have to do as geriatricians, to think just across the whole person and not just the health problems that you see in front of you, and think, well, what is this? Okay, your diabetes is okay, your blood pressure is okay, so what am I missing here? And then you sit down and you have a conversation like, tell me what's the thing that I could do for you that would make you feel better. And it's surprising what people say to you. And some people would say, I'd like to see my grandchildren more. I'd like it if my husband was still alive. I'd just like to see someone in my day that isn't coming in for 10 minutes. I'd like to be able to walk to the bingo hall. I looked after a lady that had really bad mobility, and I spoke to her about it, and she said that the one thing that I could do for her was to get her walking enough that she could use her season ticket to Brighton and Hove Albion Football Club. So we worked really hard in her rehabilitation so that she could go and attend football. So it's about seeing what people's goals are and what their life aims are. So yeah, falls, chronic disease, stroke, and it's really good that you're bringing in some of the psychosocial factors that really do play a part in what I do as a geriatrician. Back to the talk. So these are some of the problems. So you've got most of these stroke, some of these, a lot of chronic diseases are more common as you get older because you get age-related changes which make them more likely. Plus you've got years of exposure to those behavioural risk factors. So stroke, diabetes, cancers, high blood pressure, depression is a really big thing, and low mood. And because of all of those, people have to take lots of medicines, and we call that polypharmacy, when people take lots of tablets. And those multiple medications cause problems in their own right. So they're more likely to have side effects. And a lot of my job is looking at people's medicines and saying, actually, I don't think you need them anymore. And perhaps we could just do without them. And perhaps that means that we have to accept the risk that this isn't so well treated, but you'll feel better. And then in pink, I've got the sort of classical presentations to elderly medicine. So frailty-related presentations, delirium, which is acute confusion, falls and mobility problems. Mm-hmm. And I've even put in here, so you brought out these problems. Those disability and functional problems mean that some people may need some help with everyday functions, but we need to make sure they've got that help, and it's our responsibility. You can do all the clever medicine in the world, but if you don't know how someone is supported, how they're going to manage when they get home, all the clever medicine fails. So you have to really know your patients well. Where have they come from? Where are they going back to? What are their aspirations? What are their goals? What are their preferences? And we need to try and make that happen. And if you've got insufficient support, or the support you've got there is under strain, it will fail. And then other issues we might see are the social isolation and loneliness, and then neglect, which may be people neglect themselves or they get neglect from others. And certainly, sadly, we do see older adult abuse.
Tom, I'm sorry, we can still see the Menti, not the PowerPoint slide.
I am sorry. This
That's
is
right.
my, okay. I'm going to go back one slide, but I talked through it. So this is just to show you that you absolutely all chose the right things that are there. Okay. A little bit about frailty, and I can't not talk about it because it's my job. So frailty, so we as humans are complex systems, and we have to have inbuilt mechanisms that allow us to withstand whatever stress life throws at us. Infections, I told you about these, so drug side effects, the environment. If you're a very small person, if you think about a stereotypical older lady who's on Brighton seafront and it's really windy, the storm that we just had, withstanding not being blown over. So all of those stresses, you have to have resilience in your systems. An aeroplane is a system, a complex system. So it has reserve mechanisms so that it can fly safely, which is to transport a person from A to B. So it's got more than one engine. So if one fails, you'll land safely because the other engines will work. If the oxygen supply fails, they'll provide it to you. But it only works if you've got systems which top it back up again. So someone has to fix that engine. Someone has to make sure there's more oxygen. And if that doesn't happen and those reserves dwindle and you've got one functional aeroplane engine that's still running, the next thing that happens to you, so it gets hit by a flock of birds, for example, there's no more reserve in the system and the whole thing goes down because it's catastrophe. You've reached your threshold of between working and not working, and something has tipped you over the edge. And that's what we see in frailty, that over time, those mechanisms that we have to look after ourselves are dwindling to the point that we don't have any reserve. And it means that if you throw something at us, like an infection or a new environment or whatever that might be, means that you get a disproportionate change in your health status. So people come in confused, they come in falling, they come in not being able to walk very well. And these are the non-specific ways that people come to hospital. And it's actually our job as geriatricians to work out what was the stress event. So we know the system has failed, but what was the thing that caused it to fail? Was it an infection? Was it COVID? Was it their COVID vaccine? Was it a stroke? What was it? And that's our job as geriatricians. And over time, we do lose function. I've just put this in for interest in terms of the things that you lose first to the point where you get to functional decline and you're that person whose life space has shrunk and you're needing help with everyday tasks. Complex tasks go first. So complex tasks that involve you to have to do something. So the first thing that people find difficult is cutting their toenails. And I've got a picture here of onychographosis, which is overgrown or ram's horn toenails, which I see quite commonly. They may look gross to you. I look at a lot of feet, so you have to get used to that as a geriatrician also. So that's a complex task. It involves you to bend, you have to lift your leg, you've got the fine motor activity of using your hands, and then things reduce over a stepwise fashion. So you lose the things that involve you walking long distances or being outdoors are often lost first. Life space shrinks, and then the functional ability within your own home shrinks, so the ability to wash and dress. And the thing that people lose last is the ability to feed oneself. So upper limb function tends to go after lower limb function. But what about attacking grannies? Because that was my talk. So what makes good grannies go bad? And really, the thing that makes good grannies go bad is delirium. So delirium is an acute confusional state which we see in hospital. It can cause people to be quite aggressive. And I have certainly been attacked by many grannies and granddads over my training. I've been punched, I've been kicked in the stomach, I've been bitten. And here we've got Super Gerries, which is my colleague, Dr. Muna Al-Jawad, who researches through comics. And she draws a lot of comics about older age. And her comic alter ego, her superhero, is Old Person Whisperer. And she can get through to old people and work out what's wrong with them. And she says here, so behold, the geriatrician looks like a normal doctor, but she was bitten by an old lady as an SHO, which is a junior doctor, and she became the Old Person Whisperer. So that's Muna. And then I found Granny Goodness, who is a DC comic villain, who is a granny. And it says about her that she's surprisingly robust and, considering her age, can lift several tons and resistant to many forms of physical attack. And when an older adult has delirium, which is often caused by an infection, a change in environment, and operation, they get a change in their attention, and particularly hyperactive delirium, which is where people perhaps hallucinate, they are alert, they're awake all the time, they're restless, they become perhaps distressed. People can become aggressive, and you get people that do these feats of human strength, which I've never seen before. I've seen people climb up on 90-year-olds that climb up on secretaries' tables, and people that are throwing things out of windows. I've seen all sorts over the years. What's more common actually is hyperactive delirium, where people just become a bit drowsy, a bit sleepy, are less alert and aware. And the risk is with hyperactive delirium is that people don't notice it. So if it goes unnoticed, either type, it's associated with quite poor outcomes. And the chance of dying within a year of a delirium is around 35 to 40%. So it's really important that people learn about delirium and how to treat it. And this is some tips about how we can do it, which is looking for it and how we can get people to help. So making sure people's glasses are on, hearing aids are in, that we check that they're not abusing alcohol, which is common in older adults. And you've got here harnessing the power of family. So it's very important to try and orientate people as much as possible. I had a lady I looked after here in Brighton who thought we'd mocked up the whole ward, that it was a TV set, that we'd replaced her family with actors that were playing their part. I've had people that have thought that all the food is poisoned and they won't eat or drink it. And you have to find some way of getting through to them, which may be a family member, it may be a member of staff, it may be something to try and reorientate that person. And there is an idea about delirium debrief, if people remember it, to try and reduce the nature or the disturbing nature of the delirium that they've had. I'm not going to show this, but I think this will come out. But I've put a YouTube link on, and if you're interested, this is I Can Prevent Delirium, which describes a patient's experience of delirium related to having an operation, and how it affected the family, how they managed to calm him down, and how he returned back to normal, and they followed him up and his memory had returned to normal. Not all people following a delirium will return to their normal level of function or their normal level of memory and thinking, but the vast majority do. It's well worth a watch. It's only about 5 minutes long, and it tells you pretty much what you need to know about delirium. I think it's a really good watch. I'm hoping by clicking this it won't play. So I'm 2 minutes over. I'm sorry, I did jump a bit between the mentee, but thank you, and I can answer questions. I hope that was all right.